Good morning, George. It's Tuesday morning, and we're taping the first podcast of the year. Happy New Year to our guest, yourself, and everybody listening, not only in the US, but across Latin America and Europe.
Yes, today we have a spectacular guest. Every guest is more spectacular than the one before, it seems. We have Dr. Rani Gerge. He's in Miami Children's. And today we're going to talk about the state of pediatric medical education in residency and how things are different from when we were kids.
Dr. Rani is a dear friend, and he's the executive director of the medical education DIO DIE lead at Nicholas Children's Hospital, a hospital which is in Southern Florida in Miami. And it's a huge organization of pediatric workforce and extremely strong programs, very diverse programs with residents, attendings, specialists, subspecialists, neighborhood pediatricians, urgent cares, imaging centers that are staffed by people from across the world. He's also the director of my favorite CME, which is held every spring in Miami. This year, the 59 postgraduate Nicholas Children's CME program will be at Coral Gables, and it is a must for anyone who is interested in learning about pediatrics. Welcome, my dear friend.
Thank you so much. Happy New Year to both of you, and thank you for having me back. Hope you had a great holiday.
Thank you. Dr. Randy, tell me more about this phenomenal hospital called Nicholas Children's down there in Miami, Florida.
Nicholas Children's Hospital is formerly, some people know it as Miami Children's Hospital, historically. It's a freestanding children's hospital, around 300 beds, all pediatrics. It's a nonprofit. Actually, in 2025, the hospital will celebrate its 75th anniversary. So next year. So it's been in existence that long. And actually, from a medical education standpoint, it was accredited the very first time by ACGME as a sponsoring institution or as a teaching hospital back in 1962. So it's been teaching generations of pediatricians over the years. And it's one of three freestanding children's hospitals in Florida, in the state of Florida.
How many attendings do you have? About 700?
Yeah, our general medical staff is around 680 or 700, but we have around what we call here geographic, which are more really hospital based that practice in the hospital. Around 300 of those or 350 are actually practice is based at the hospital, or either they might be, and most of them are employed by the hospital or by the practice, the hospital. And some of them are private practices who basically lease out space at the hospital for their clinics, which helps a lot with training because then the attendings are actually always available here. It's not they come around and they leave somewhere in the community to go back to their offices. Their offices are here. They work well with both inpatient and outpatient with the residents.
And you have thousands and thousands of surgeries a year, don't you?
We have thousands of surgeries a year. We have our ER is one of the busiest pediatric ER in the country, around 100,000 visits a year. That not counting the urgent care centers and the non-emergency, kind of the acute care. And just the ER itself on campus is around close to 97,000 or 100,000 visits a year.
And you're also one of the centers in pediatrics that is very advanced or innovative, using focus point of care ultrasound, both having a credentialing program for pediatricians that want to learn how to do that. And it's heavily used in your emergency department. Do your medical students and residents also use focus?
Yeah, absolutely. We do have a fellowship in pediatric emergency medicine, and some of our fellows actually, both in ICU fellows and emergency medicine fellows, get trained. And some of them actually last year did help with the workshop at the course last year as well. Some of the fellows were used as trainers, but also our residents when they're in the emergency department and or in the ICU and the PICU, and they get exposed to doing focus for putting blinds, doing IVs, doing any procedures as well on the bedside. So that's used a lot for training. And then also we train ER residents who are from outside programs. So they're adult kind of ER residency programs who are in the country and the community who come to us for pediatrics. So we train a large number of rotating residents who come to us from outside Nicholas Children's, who are sponsored from Mount Sinai Medical Center here in Miami Beach to HCA and other institutions that send their residents to us for pediatric training.
Well, and you have two chief residents. One of them, Camila Garcia, who is from where I trained in medical school from Costa Rica. How many how many residents do you have? And tell us about how diverse that community is within your hospital.
Yeah, we do have our residency program is one of the largest in the Southeast. So we have 84 pediatric residents for general pediatrics, so 28 per year, and then two chief residents. And we have around 44 fellows that are spread among 16 fellowships in different specialties. Also, uniquely, the hospital has also a pediatric dentistry residency program that has 10 residents. It's an accredited program. Again, pediatric dentistry is very underserved in nationally. There's not many enough pediatric dentists to take care of pediatricians. And we also have psychology interns and pharmacy residents as well. Mental health is big for us. And our residents and fellows in all departments and even in psychology and pediatric dentistry come to us from all over the country, all over the world. It's actually nice because as Miami is a very diverse city, so it reflects the diversity of the city of Miami because people feel belonging by coming to Miami and assimilating with the culture here. We have residents from obviously being in South Florida, we attract a lot from South and Central America, but also we have residents that come to us all the way from Middle East, from Israel, from Saudi Arabia, from other places as well. Again, also the weather helps.
Yeah, very diverse, 70% female.
Yeah, 70 to 75% females. We track these data as well from year to year, looking at our diversity and inclusion. And yes, which mirrors a lot the nationally as far as pediatricians. But also, even in surgical specialties, we have a lot of surgical specialties in our fellowships. And like our pediatric neurosurgery department is all females, which is our Dr. Ragel, who is our chief currently, is retiring. And the 4 pediatric neurosurgeons that are left running the department are all females. So even in surgical specialties.
Now, what percentage of your residents go on to primary care on the aggregate over the last 10 years, not just 1 year?
Yes, you're absolutely right. It does vary from year to year, depending on the class and depending on kind of nationally what's going on in the different specialties. We usually have around, it varies from 50% of the class to 30% of the class going into primary care. Usually, obviously, since we are a tertiary care center, the residents get exposed to a lot of the subspecialties. A lot of them end up being interested in one of the subspecialties. However, recently we have witnessed a couple of years ago a little bit of an increase in interest in primary care, or since now hospital medicine is an accredited fellowship, before people used to go into inpatient hospitalist jobs after residency. So some of them are going into that as a fellowship for an extra 2 years.
Yeah, back in the day when we were kids, most people went to the general peds. I can tell you from being on the other side, I don't know about your statistics, if they all just stay in Miami afterwards or whatever. We're finding that most of the residents from within our community are going into specialty medicine, fellowship of some sort. Very few people are going into general pediatrics. We're having a tough time recruiting physicians, even with headhunters.
Wow.
What do you think could be
What is it?
done to help more, Rani, what do you think could be done to help more pediatric residents and medical students become what I call neighborhood pediatricians? Because it's not just New York, Rhode Island, Idaho, and pretty much anywhere outside of Miami and California. There's not enough neighborhood pediatricians to meet the needs of our society.
Yeah, that's a great question. And this is something that several of the organizations that impact training of residents in primary care, for example, the American Academy of Pediatrics or the American Board of Pediatrics, are aware of that and they have worked with the ACGME in, in changing. There are new requirements that are coming up in 2025, July 2025 for general pediatrics. Because historically, as we all know, many times the training of general pediatricians has been heavy on inpatient, ICU, NICU, PICU. Sometimes it's really exposure. If the general pediatric residents are not exposed to what a primary care pediatrician does in a community, and they're more really exposed to they only comfortable taking care of very sick children in the ICU, that's all what they know. So exposing pediatric residents, having them actually go out in a community health center or a pediatrician, primary care pediatrician setting, the new requirement actually will focus on that. There is a little bit of a shift from decreasing the number of the and NICU that are required and shifting to more outpatient, community-based experiences. Mental health is going to be a requirement similar to development and adolescent medicine. Now, mental health is going to be a component of it, which is we know that pediatricians now more than ever has been dealing with mental health issues and many communities might not have enough psychiatrists or mental health counselors or psychologists to even help the pediatricians. So similar, we've seen this back in the day when ADHD became a big diagnosis that the pediatrician needed to be trained in diagnosing ADHD and starting the treatment. And then if it's a complicated case, they refer to a behavioral specialist. AAP at that time, during that time, the American Academy of Pediatrics came up with the ADHD toolkit to help pediatricians into the screening and the starting the meds. And so we're going to see similar to that to related to mental health, depression and other features of mental health. And I think having the trainee exposed and comfortable in caring for healthy children or caring for primary care issues will actually help a lot of them actually go into the field. We've seen actually some residents who come to us initially set on a specialty and they say, I want to be cardiologist. I want to be, when they start their residency. And then depending on the experience that they have in residency, and if they were maybe sometimes the mentors that they work with, most of them, they were like, oh, I like cardiology, but I like more the continuity. I like more building the relationship with the families and seeing these kids grow.
Right.
So I'm going to be a general pediatrician. And I think really to go back to your question, I think exposure and residency to
Well, exposure is important, I think. They do all these lectures and conferences and certification programs. I did one on behavioral health just because I thought I should do it. Did anxiety. I wasn't formally trained in anxiety and depression, but I know how to recognize it. Do I know a whole lot about the medication? I probably could learn it, but their focus was not on the bread and butter things that you would see. They talk a little bit about anxiety, depression, a little post-traumatic stress, a little bit of ADHD, which is easy. Then they start focusing on the really heavy duty, hardcore stuff like schizophrenia, bipolar, manic depression. Really? I'm going to deal with schizophrenia in the office. That should be left to the real specialist.
Right.
But that was their focus and it turned me off.
Yeah. But you do have a very positive experience, George, to Dr. Rani's point about having medical students rotate through your practice and what a difference it makes in what they think about the neighborhood pediatrician and the
Right.
special pediatric.
I think that's where it all starts at the medical school level. Again, we have one school that comes to us. And I've been doing this for 3 years. I have one student a month. There's about 5 of them, all the attendings have. We have yet to meet the one student that comes in, Dr. Rogo, I want to be like you. I want to be a pediatrician. Doesn't exist. They want to do surgery. They want to do specialty. A lot of them want to do family medicine. Not so much internal medicine, but family medicine. And I think it's a push from the school level. The school is heavy duty on pushing family medicine. And it's pretty sad. Nobody wants to do peds. And then they leave the rotation. It's the most popular rotation at their school.
Yeah. So when you were rounding on that kid in the ICU, you met 2 or 3 students that rotated through your office, and
Yeah.
they had nothing but great things to say about the specialty
Right.
and the pediatrician, right? So
Right.
to Ryan's point, I think exposure is key. If they have positive experiences like the students do in your office, they're more likely to go out. Number 2 is going to be being able to pay them well. People are not going into primary care because we are not investing in primary care. And so why would you go make $150,000 a year after 11 years of training when you can go make 350,000 by being a specialist. These are not dumb people that are going into medicine. They're smart and they don't want to live in a one-bedroom apartment the rest of their life. So the other one is funding. I'd be a little concerned. I had a lot of PICU and specialty and not so much NICU, but a lot of PICU experience as a resident. And I thought that gave me the confidence of treating any child at any time, anywhere. I saw some train wrecks. And I was telling George, when he told me about this little guy in the ICU, I said, look for a midgut volvulus because I almost lost a patient in Chicago to that. And it was one of the most difficult patients to manage as a resident. And they present to sepsis.
Yep.
But that really does give you, I guess, the courage to deal with anything that comes in your door and not be panicked. Your thoughts, Dr. Rani?
No, absolutely. And that's, you have to strike a healthy balance as far as when it comes to inpatient, outpatient, ICU versus the regular floor when it comes to training. And really the ACGME only went down on the total number of PICU, NICU together by one rotation only down.
Okay.
However, as we know, some hospitals run totally on residents. And so technically ACGME gives that as a minimum. Let's say the old requirement says you can do 4. So to NICU to PICU is the minimal. So you can't do less than that. But some programs are doing 6, 7. So it eats out into the residents burnout. It eats out maybe for people who are interested in primary care, where they're going to end up. They don't have any experiences for them to go out and do advocacy or to go to a school so I think ACGM is trying to strike this balance where there is now 6 individualized blocks, part of the 3 year of training, that actually the program director together with the resident based on their training goals, they could actually, we used to call it selective and electives. I guess they could actually tailor towards so somebody who's wanted to do ER as a fellowship, they could do, instead of the required 3 ER rotations in the 3 years, they could do a transport. They could do extra stuff that could actually expose them more to so absolutely. ICUs are very important. I think it teaches a general pediatrician how to deal with the sick kid in their office while waiting, and especially if they are in a rural area where they maybe EMS is a little bit far, it helps them advise schools and others. So I think, and that's really there was a lot of discussion back and forth to the point that even there was on the table an idea about, now there's so much for pediatricians to know. And with the cut down on the hours, does pediatric need to be 4 years? Actually, I just learned that Canada just went into a 4-year residency program. The problem in the United States becomes there's a lot of trickle down effect as far as funding and all of the others unintended consequences. But so it's almost like you're stuffing the sausage with all this information that now pediatricians have to do in their office that didn't used to do before.
So now you're going to get me on my soul. Absolutely opposed to making the residency program any longer. It should be shorter.
That's not going that way, but I'm saying that what have the floated.
Yeah, yes, I understand. And we became aware of the Canada in one of the other shows because we're not playing in a level field. It is a very unfair field. And I have deep respect for physician extenders, PAs, and nurse practitioners. They have a role within the health system. But it is not fair to ask a young woman, because 70% of pediatrics is women, who's a medical student, and I'm thinking specifically as someone that's in Miami, who is passionate about pediatrics, to do 4 years of college, 4 years of medical school, and 4 years of residency and be treated as an equal to a physician extender. And so we have to be honest and we have to say things as they are. There is a role for nurse practitioners and PA. They do a wonderful job, but they are not a pediatrician.
Yep.
And we cannot put this burden on young people because we don't have enough pediatricians.
Mhm.
And in my mind, the Canadian model, the Costa Rican model, I don't know if in Lebanon the model was the same, but pediatricians in Canada, Costa Rica, and other parts of the world, Lima, Peru too, they continue taking call either at a community hospital or a children's hospital. and they do everything. They attend the NICU, they attend the deliveries, they back up the emergency room, they do the inpatient ward, and they may do that 1 day a week, or if they want to 2 days a week. They're heavily compensated for that work, and then they have their private practices where they see all the well child exams. And I think it makes more sense from a work development force and avoiding burnout for those people that really want to be committed to a neighborhood pediatric program to only do 2 years of residency and have an extended career of 5 or 10 where they attend at a children's hospital or a community hospital that has a big children's ward and program so that we maintain our skills. Because that was one of the pities. Once I stopped doing emergency room, I lost all my critical care skills. And no one wants me because we're not set up to do that. I'd be glad to work one 24-hour shift a month at a children's hospital with the residents and take care of critically ill children and maintain that through my career, and then go to the community and serve kids in a different way 3 or
Mhm.
4 days a week. And I think we need to be thinking out of the box. We need to really strengthen our workforce. Another one, I'm going to get killed for this. I think if you're a foreign medical graduate on a J1 visa and you commit for 5 to 10 years of neighborhood pediatric, you should be given a green card and say hello. Because again, we have a workforce shortage, and we're letting these incredibly talented human beings that want to train in the US leave when we could have a great community pediatrician. Now, the pushback there is political in that Costa Rica, Lebanon, Romania, Peru, name the country, they're glad to have their physicians come to the US and train in pediatrics, but they want a guarantee from the US government that we're not
Yeah,
going to poach,
we got to
that
come.
we'll send them back because they don't want the brain drain. So it's a diplomatic problem, not a lack of will from Democrats or Republicans. It's a brain drain problem. Other
Yeah,
countries don't want their best to come here and never go back to teach in their countries and take care of their own kids. But yeah, we need a solution and quick because everybody's hurting. And if there's no pediatricians, there's no access, there's no equity, there's no care for the children.
yeah. The brain drain is a real thing because every single friend other than her that I have that's a physician in the United States is from my medical school in Romania. They all left after the Berlin Wall fell down. They all
Right.
hit the United States. They're all in New York.
Yeah.
Yeah,
Yeah.
Like a generation of doctors vanished.
Yeah. Yeah. And to your point, there is in the United States currently, because we do sponsor the J1 visas for our foreign graduates. There is a path through, as you guys know, through the serving and going to an underserved area or a J1 waiver for a health professions shortage area, a HIPS designated region, which is, so at least there is some type of path for them to end up getting the green card. But you're right. It is a brain drain when you look at it from the origin country of origin itself, because then people never go back and contribute to their country.
Yeah.
yes. And look at it from this perspective. Two of my very good and dear friends are from the American University of Beirut, Dr. Claude Karam and Dr. Rani, right?
Yes.
Y and and they're here in America. They're not taking care of children in Beirut. So it's great for me, it's great for our kids, but the kids in Lebanon also need high talented pediatricians, and I'm sure they have them, but they lost 2 of the best, right? So that's a problem. Now you have a phenomenal record at Nicholas Children's of residents that want to go into fellowships. They go into Stanford, Hopkins, Boston Children's, Vanderbilt, and St. Jude's. Did I miss out any of the great institutions that other than Nicholas Children's that they go on to?
We do also send a great deal to MD Anderson in Texas, for Texas children, Cincinnati children. We had quite a few this year going there, and then Denver children this year as well, and Children's National. So one trainee goes, and then they pave the way for more. At one point at MD Anderson, out of 9 fellows in Hemong, 6 of them were Nicholas Children's alumni.
Oh,
Well,
wow.
how they paved the way. One brings another, and a friend tells another friend.
And the program is happy with them. They feel like they're well trained. So we look at it as a very good positive reflection on the program.
What does the, fellow that went to Denver, go there for? And in the chronology or
We have this year we have a hem-onc and a GI.
okay.
We have a couple of yeah.
Oh, I did see that one of your residents went into a fellowship of endocrine. Talk about another area of pediatrics that's really a workforce shortage
Yes.
and a self-inflicted wound. So when I was an intern in Kalamazoo, Michigan at MSU, there were 2 community pediatricians. This is how the town worked. There are 50 pediatricians in town. They were the referral area for all of Southwest Michigan. And there is, I'm gonna say an old guy because he was a Canadian that was much older. I don't know how much older because when you're in your 20s, a 40-year-old looks older. Uh, it's true.
It was
And
like you. I guess he was like,
no, he was old. I wanna say he was in his 60s when I was in my 20s. 'Cause he
Yeah.
would to tell me about using I think it wasn't formaldehyde, but what was the anesthetic? He says in Canada, they would put ether on a handkerchief, put it over the baby, and because there was no antibiotics, do the myringotomy in the office. And he
Uh-huh.
said, "We never had any problems with that." But, of course, this was 40 years before pulse oximeters.
mm,
Uh, and then he was huge into diabetes. And in teaching. And then there was a young guy who was about 3 years out of residency, Dr. Page, who also had an interest in diabetes. And the other community pediatricians would refer to them. They're diabetics, and they would send them back, but they weren't trained as endocrinologists. And there was another guy that had an interest, Dr. Feinberg had an interest in peds endocrine, so they would send them complicated endocrine cases. And like at your store, George, there was somebody like Dr. Riley that was interested in lipidology and obesity, and the community pediatrician would send it to, and there was a collegial environment. You never took anybody else's patients. But we did shoot ourselves in the foot when we stopped taking care of our own diabetics and let the endocrine people be the only ones that have that skill. That's another skill that I lost. It's a lot of loss, a lot of ground to make up in pediatrics. Anyhow, um, you serve on multiple committees I can't even keep track of in the American Academy of Pediatrics. I think the one I like the most is the NCA committee. What do you do there, and what can you share with the audience about NCE Orlando 2024?
Yes, it's actually one of my favorite committees as well. I did serve on that committee initially for 6 years, and then I rotated up the committee, and I became a member of the committee on CME for the American Academy of Pediatrics. And then 2 years later, I became the chair of this committee. So I'm currently the chair of the committee on CME. And as the chair, you get a seat on the NCE prompt group again. So I went back for another term, which is great. I was so happy about that. It was not my intention, but that was awesome. What we do on the NCE planning group is we look at submissions of proposals from different sections, councils, committees, and throughout the AAPM membership. And so proposals get submitted for sessions, workshops, or lectures. They are usually sponsored by the section or the council or the committee of a certain council, or sometimes it's one session could be sponsored by multiple as a kind of a supporting committee, depending on the topic. And then members of the committee are divided. So let's say I might be in charge under my name, let's say 5 sections. And so I'm their liaison to the committee. And then but more than one member of the committee reviews and scores independently those actual proposals. And then they got rated. And then we meet together, and then because we get around 400 to 600 proposals submitted for NNCE, and then we have to pick around 250 for the conference. So we rely on a lot of the peer review and scoring, and then we look at the previous years, whether they just had a topic that had been done before, if it was attended well or not well attended. We look at data also from what's going on nationally at that time. Is it a hot topic or not? Is it going to be popular, or maybe the audience as well? Maybe sometimes the topic is great, but maybe the large audience of NCE is general pediatricians. Is it going to have an audience? Maybe it's too subspecialized, and maybe it may not be fit for that. So we do that. And this year, the past couple of years, what we did is we noticed that a certain subset of lectures or topics we always accept because they're basic, they're bread and butter. We always used to accept them because they're well attended, dermatology, ID. So we created what we call a core curriculum. So now out of the 250, maybe 100 topics are actually what we call the core that could repeat either not the same session, but the same kind of overall topic every year or every other year, depending on the need. And then the rest would be the other 150 would be new or new types of proposals. What is exciting about 2024 NCE, it will have obviously the same feel of NCE as far as a huge number of choices, workshops, sessions, networking. A huge focus this year is a lot on mental health, on physician health and physician well-being and physician safety. Practice management is always a huge topic and remains as such. And then also we have a lot of, obviously, some very popular topics that always are well attended, like the top 10 articles of the previous years in pediatrics, like dermatology with audience response. Those are usually a big hit as well.
And what topics are you in charge of? You said they split it up, so you have 5 that you are supposed to.
I have research, medical education, I have school health, and then I used to have oral health as well. But since when I rotated off, it belonged to somebody else. But since I'm only representing the committee on CME, what is under me is more like medical education, simulation, research, and
And so how does one, if I wanted to apply for a topic, say autoimmune diabetes of childhood, how would I write you an email? Would I write Dr. Susan's Road an email? What is the formal process?
the formal process is normally AP usually they announce when the abstract submission or the proposal submission open. It's an online process and anybody could submit. They usually advise that so let's say if it's an endocrine topic, is maybe to get it endorsed by the section on endocrinology, because technically they help us with finding the speakers. They help us with suggesting, we know from them about if they're coming up with a new policy statement, and maybe this is a great topic because it's linked to a policy statement that's going to be coming up soon. And maybe pediatricians need to know about that. Usually the process is you can go online and submit, but it would be good to have an endorsement from one of the section or councils that's related to that topic. And then because there is a drop down that asks you, has this been endorsed? And then you choose the section that endorsed it.
Okay. That's pretty cool. And
Yeah.
then you also serve at the state level and district level at the AAP and multiple other medical organizations. What are your passions there and what do you do there?
Yeah, at the state level, I am with the Florida chapter of the AAP. I am actually one of the 2 co-chairs for the Florida chapter conference. Also, the chapter conference is usually on Labor Day weekend in Disney. So I'm the co-chair of the planning committee for that conference. Also, I'm on the editorial board for the Florida Pediatrician, which is the Florida chapter of the AAP journal. There's a journal that gets published by the Florida chapter, and I am on their editorial board. I do, in addition with AAP, in addition to being the chair of the Committee on CME, I'm the member of the COPE, which is the Committee on Pediatric Education. And then also I'm the CME editor for Pediatrics in Review. So I actually write and edit the CME questions for the articles that are in Pediatric in Review. The 15 questions that normally are with the 3 articles. I do that as
Wow.
well.
When do you sleep then? All right. So now you have a lot of titles, and I don't know what the executive director of medical education does at a medical school or a children's hospital. What is it that you do at Nicholas Children day in and day out?
I'm sure. Basically, I feel my job as a executive director of medical education is actually exciting and unique because in most schools or university setting, the job that I do is three different departments. So you have the CME department or faculty development or for faculty and for attendings. And you have the graduate medical education, which is residencies and fellowships. And you have the undergraduate medical education, which is medical students, rotations and stuff. My department deal with all three of those in one big department because we are more like one department of pediatrics in a university because we don't have adults in our hospital. So actually it's cool because honestly, I look at medical education as a continuum and what the attendings need to know about teaching or about new requirements from ACGME impacts the GME training of residents and fellows. So part of my job is ensuring compliance with accreditation, whether CME accreditation, our CME accreditation, our ACGME accreditations, making sure that the programs stay in compliance. I am the DIO, which is the designated institutional official, which is in ACGME terms. I'm the link from the institution, from Nicholas Children to ACGME for the training. We do plan a CME offerings. So in addition to the course that you alluded to, our postgraduate course, we do plan what we call recurrencies here at the hospital. I oversee grand rounds. We have a radiology conference. We provide CME for them, tumor board, trauma conference. And then we also put together a big board review course that used to be, if you recall, used to be attached to the postgraduate course. And now it became a standalone course that we do in May to help third-year pediatric residents with their board pass. And actually, we've done that course for 27 years now. And I'm happy and proud of our residents. We always are one of the highest board pass rate in the state of Florida among all the programs. But we get residents from all over Florida, from all over who come to take that course. I also manage the MOC Part 4 for our institution. So for our faculty, for QI, all of the QI projects that are done by residents and fellows and with the faculty, they get MOC credits for them. And then I also teach residents and fellows and medical students. I give lectures to the core curriculum for the fellows and on research and education. Or I also teach faculty, do faculty development on how to teach, how to give feedback. And then I teach medical students. I have a couple of lectures that I do on the core third-year students on fluid electrolytes, on sports medicine, which is one of my passions as well. And then for our pediatric residents, I teach sometimes clinical topics, but also I run the evidence-based medicine curriculum for the residents.
So it seems like there's a whole lot of teaching and education and lectures and all this stuff, which is great. Herb missed a big question. How has residency changed? It changed a lot from when the three of us were residents. What stands out to you?
Yes, it did change. I think
A lot.
A lot. Yeah. We all definitely, the obvious one is the duty hours. Obviously, when we went to residency, we didn't have the 80-hour limits. We didn't have the getting the day off post call. You can be post call and you go to the clinic in the afternoon. You may or may not sleep through it. Trying to stay awake. I think there is more focus in residencies now on interprofessional education in the sense that even though the residents don't have lectures together with other professions, but there's a lot of teamwork on the team itself. There is a lot of the QI projects, for example, is a requirement now for residencies. And in order for a fellow or a resident to execute a QI project, they need the help from the front office staff, or depending on the topic, or from the nurses, or from RT, or to actually move their QI project along. So that actually teaches them that medicine is a team sport and they need to help improve the care. It's everybody's job. The other thing is, even though we notice sometimes with the EMR, there is in how prepared students are graduating from medical school to the real role of an intern or a first year resident, because depending on what the medical school allows them to do, some schools don't let them document in the EMR. So then as students, we all wrote notes in the chart and they got co-signed by somebody, by the resident or by the attending. We wrote orders and then somebody co-signed them, especially in our fourth year. When you're an sub-I, you really acted like an intern. And nowadays we notice, depending on the school, it's not any more standard. Some schools allow students to document in the EMR. Some schools don't allow them, or they document into a totally fake EMR. Some schools, actually, we notice more, obviously, the foreign graduates who come to us from foreign medical school, they do more in their school. So they're probably a little bit more prepared from that standpoint. Maybe the system is different for them as new, but so we notice that. And then the other thing that we notice is the new student generation. Like when we interview applicants, I'm always amazed how much the students are doing in their medical schools, in addition to going to medical school, which many times we did not have time to do anything else. I've seen applicants who started an NGO, a nonprofit organization for something. And I don't know where to start if I want to start an NGO myself,
Right.
let alone to have a student who's done that. There's a lot of driven people, and it's almost because the field has becoming more competitive. People are doing more in outside the medical school and community, or they started a free clinic somewhere. And it's amazing. The school itself changed. The going to medical school changed. Residency has changed.
Mhm.
But like I said, the work hours is one. I think that the fact that there is more interprofessional education and focus on quality and safety, which is a big thing in hospitals now.
Yes.
And that's definitely a huge, because it impacts supervision. Residents are more supervised than ever before.
How do you think that impacts decision-making skills?
It depends on how you implement it. Like in our institution, residents are always supervised, even if they're third years. But when they become third years, we let them do a lot on their own. There's somebody there, but we make an intention to give them progressive autonomy. So our residents, our third year residents as team leaders, after midnight, they are still like we were before. They are the ones running the show. They have an attending on call with them. We still, in our institution, we don't have 24-hour in-house hospitalists. Our hospitalists stay in-house only till midnight. So after midnight till the morning, the third years. And I think that's a good thing, because it
It's a good thing.
gives the autonomy decision making, and with the backup of an attending who's home after midnight. I think it's depending on how you implement it. I think if too much supervision is not good, and
Oh, yes.
supervision is not good either.
Yes.
Do you still see patients once in a while, or
Very rarely. I used to be a hospitalist at one point, and I like inpatient more than outpatient. I actually like the model that used to be that we just talked about earlier, where you do both and you go to the
yes?
nursery. And I've done that a while back before I moved to Miami. I did it all. I did nursery, and they did inpatient and outpatient. Here at the hospital, outpatient gives you more flexibility in actually precepting in the residence clinic whenever I am needed on the schedule. I still do, but not as much as I would like to. But
Yeah,
again,
you're busy.
with all of the other duties, it's hard. But if I
Yeah,
do, usually it's outpatient, it's in the residence clinic precepting.
yeah. Because with your passion for school-based medicine and sports medicine, that would allow you the flexibility to do half a day of just sports physicals, or go to the
Yeah.
school and do the sports physicals with a resident and medical student for the football team for free. That kind of thing, which is very enjoyable in it. And
Yeah.
you don't have to be worried about the follow-up because it's a one-time event. But it keeps you, I, taking care of the kids is fun. It keeps you there. All right, now let's talk about what I love. The crown jewel of your program is the postgraduate CME program, which has been in existence for now 59 years. It used to be, I don't know if you're old enough to remember, but it used to be held at one point at Ball Harbor's Sheridan, which is now St. Regis. And it was a week-long event. And I met some great luminaries of pediatrics like Dr. Ralph Feigenach. And it was great because that hotel had a lazy river, and you could take your kids with you, and they would float in that river all day while you were doing your CME. And it was, and you met the best pediatricians from around the country, both in academia and not in academia. The kids had a great time. The facility was great. Now they plowed it over, and it's a St. Regis. I'll never be able to stay there. But so, where is that held now? Wait,
59th annual and 2024, it's going to be held at the close to home, close to our campus in the Nose, a beautiful venue in Coral Gables, in the heart of Coral Gables, here in the Nose Hotel, a fairly new hotel that opened in November of 2022 of last year.
that is a gorgeous hotel, isn't it?
Yes, it's a beautiful property, great location because it's walking distance to Miracle Mile, walking distance to a lot of the shopping areas, and centrally located to Coral Gables, Coconut Grove.
Before the pandemic, because it's hard to tell, when during the pandemic you had to go virtual. How many neighborhood pediatricians from the US attended the live session?
Yeah, pre-pandemic, and as you mentioned, I've heard about the Bell Harbor. That was before I joined the hospital, but before the pandemic, we used to get around total of 400 attendees. Around, I want to say 50% of them were international, but the other 50% were pretty much primary care pediatricians from local and obviously from all over as well. And I want to say that before even live streaming was a thing during pandemic and after the pandemic, now it became part of every conference. We did even in 2010 when I joined the very first, I started my job at Nicholas Children during the weekend of postgraduate course in February 2010. So they said, don't go to the hospital, just go to the Intercontinental Hotel downtown and attend this.
Yes.
It's our conference next year. You're going to have to plan it. So we were streaming back then in 2010, back then to Ecuador, Peru, Colombia, streaming from the cath lab, from the hospital, sometimes cases as well. So
It's amazing. It's like a TV production. When you go to the meeting, there's a whole control room and it's being simulcast in Spanish to Latin America. In the US, physicians can also access it in English, correct?
correct,
Yeah.
correct.
So
And
but it is an amazing endeavor. It's like what one would think like yesterday with the Michigan game, what it would look like to produce the TV for the Michigan game. Now, you always have a huge BID component. The last 2 years, Dr. Marianne Jackson, the dean of the medical school and a pediatric infectious disease pediatrician, was there. Is she coming back by any chance? I love chatting with her.
I know we love having her and hosting her here, and we're really thankful that she came to join us the past few years. Actually, unfortunately, this year, Dr. Jackson will not be joining us, but you're right. We do have a big ID component. We feel like ID is a big bread and butter for the general pediatricians. And this year, our featured ID speaker is Dr. Peter Cortez of Texas Children's. He is a section of head for the pediatric tropical medicine at Texas Children's, and an endowed chair and the director for the Vaccine Development Center at Texas Children. And obviously, you guys know Dr. Cortez was instrumental in a lot of the vaccines, including COVID vaccine that was developed as a re-vaccine for the underserved community.
And he's written a book recently about misinformation. And for those of you who don't see it, he's the guy with the bow tie. And then you're going to have a breakout session with one of the team leaders, pediatric computer company. And she's going to be talking about, I always call it pediatric, but it's a physician computer company, PCC. And she's going to be talking about coding and what else?
She's going to be talking about coding, but we're going to focus this year, the session as a workshop, and she's going to focus on caring for the complex patient and the coding and getting paid for it. Because a lot of as we know, pediatric practices many times have very complex patients. A lot of places also hospitals are creating complex care clinics as well. And I think there is a lot of missed opportunities sometimes as far as from the coding perspective and practice management in caring for those patients. Some of it is related to case management and organizing the multidisciplinary approach to actually doing the regular care. So she's going to focus primarily on coding for the caring for the complex patient.
That's very important. Just as an example, at RBK Pediatrics, where George practices, Jim does a lot of the lipid and obesity, and they're very intense 45, 50-minute
Yeah.
consult. And it's hard to maintain the wheels on the truck running when you're one clinician's taking that much time. And Nick, George's brother, is a pediatrician. He does a lot of his attention deficit disorder and mental illness. And again, it's the same problem. These are complex patients that can take 45, 50 minutes. And it's very important to know how to get paid for the work that you're doing.
And it was very interesting because we started doing some data analytics with the help of Herb. We created a nice financial dashboard for us, looking at how people are doing and so forth. We discovered, unfortunately, that Dr. Riley, who is a great person, doing a great job, doing great medicine, and making a difference, used to be a top earner. He's no longer a top earner, and he sees less patients, generates less income. Now, for us as an organization, it's okay because we have other things that help. So this helps with increasing contracts. It helps with pay for performance and quality incentives. But if he was to do only that, it would be a disaster.
Right.
If he was hospital employed on the RVU system,
He wouldn't
he,
make money.
he would be shown the door. But you have your organization, George, has a wonderful mission driven,
Right.
and you're willing to accommodate this because it's good for the kids
Yeah.
and it avoids physician burnout. And so there's value in that, although you're not counting the RVUs.
But you know
So
what? The thing is, at a hospital system or whatever system, you have an MBA suit that looks at the numbers in a bean counter.
yes,
That MBA suit in our organization is made, the physician.
yes,
So we try to find ways to make it better, and we look at the whole big picture as an institution as opposed to a one.
yes,
But how many of me's are there?
not many. Thank God.
Well, absolutely right. And that was one of the goals of doing this workshop, is because we've heard before from former graduates of the program who maybe joined a practice, and one of their interests is to care for children with special needs, but then they were not supported by the practice just because they were not making money. And there was, because of the time it takes, and there is ways to actually do it. So hopefully we'll encourage people to keep caring for these children because they need us.
Generally, the children that have these chronic care problems and all these special needs things, they end up on what program do you think they're on? Herb, your favorite program, some state Medicaid program. And they're the number one offenders of lack of payment for these services.
Yeah. Yep. That's another issue that we talked about before. Making our workforce healthy, it needs to include payment,
Yep.
payment for the work that we're doing.
I mean,
Um,
you can't do an obesity visit on $54. I'm sorry.
no, it's
Mhm.
impossible. You have added something that's very important, and I'm so relieved, to the CME course this year, which is the DEA MAT Act. So how is that going to work at the course this year?
Yes, we know this is the MATE Act, the 8 hours of requirements for opioid CME that's required now for anyone who has a DEA license. Obviously, there are few specialties that were exempt because they deal with opioids all the time, like anesthesiologists, pain management specialists, and the likes. We're trying to help our pediatricians meet that requirement. We embedded into the general program 3 hours of topics that meet the DEA MATE Act related to opioid and pain management. We do have, in addition, knowing that since we know some institutions may have offered it before, and some pediatricians may have actually maybe completed that requirement, but some of them did not. So that's why we put only 3 in the general program and then 3 in the evening, additional ones. So people who don't need it, they don't have to do it. But people who need it, by the time they finish the course, the postgraduate course, they would have 6 hours out of the 8 hours completed. We know that a lot of states like Florida, controlled substances, 2 hours of controlled substances is required for relicensure. And those 2 hours count toward the MATE Act. Technically, you can double dip on those. Technically, 6 hours plus the 2 for relicensure will actually make up the 8 hours that pediatricians need for the federal one, for the DEA one.
Oh,
Right.
great. So that'll be really helpful because that's not easy to find as a pediatrician, a CME that's specific
For
to pain
pediatrics.
management in children. I really don't want to know how you manage pain on a hip replacement of a 65-year-old. I care. That's what the orthopedist does. And so tell us again, where can people find the course? And we'll put it in the show notes.
All the information for the course are on the website, which is www.pgcpip.com.
Okay.
So Pediatric Postgraduate Course Perspective in Pediatrics. So pgcpip.com.
And the dates are?
The dates are March 22nd to the 24th. It's a Friday through Sunday. There is an opening reception on Friday night, at the end of the first day of the course, and then we try to adjourn on Sunday around 12:30 to allow people, if they don't want to take time off, that maybe they could stay another night and enjoy Coral Gables in Florida and Miami in March. So it's March 22nd to the 24th, Friday to Sunday.
And the hotel where you can get a special room rate and the conference will be held is the Lowell's at Coral Gables, which is a fairly new property in the heart of Coral Gables. There's ample restaurants, nightlife, and shopping, not only in the Miracle Mile, but a little bit up the street in Brickell. The Brickell Mall is fascinating and one of the most beautiful open air malls in the country.
Oh, just what my wife needs to hear.
I'm thinking about Delia. She can go shopping in the Miracle Mile. The pool's a rooftop pool at the hotel. And then Brickell is just unbelievable night scene restaurants and shopping. So you get to go work during the day and then have a blast in the evening. I will be attending as I do every year, and I hope to see you there. Before we close out the show, very special thanks to Dr. Rani. And I'm hoping this year, Dr. Rogu, George, will be attending the conference, and Dr. Delia Rogo, his wife, will be there at the pool and shopping with us. Before we close the show, Happy New Year to everybody, and I have a special message. A special thanks to our Spanish speaking audience in Spain, Peru, Colombia, Costa Rica, Honduras, Mexico, Argentina, and Guatemala. Bienvenidos los amigos de habla española. Estamos en este episodio grabando acerca en el Hospital Nicholas de Niños en Miami. Este episodio está dedicado a todos ustedes que nos escuchan en Latinoamérica y en especial al Hospital Nacional de Niños en Costa Rica. Este episodio será traducido a español y puesto en nuestros canales con el Dr. Rani y el Dr. Rogo. Esperamos verlos en la conferencia o el congreso en marzo 22 en Coral Gables, en Miami, con el Dr. Rani y el Dr. George para informarnos sobre pediatría. Si no puede atender, entonces haga el simulcast y aprenda sobre la pediatría en Estados Unidos. Hasta entonces, muchas gracias y feliz año nuevo. Thank you.
Did you get that?
Got it. Well done, said. Thank you.